Good evening. Columbia Global Centers Mumbai and Columbia Global Centers Nairobi welcome you to the first part of our webinar entitled Oral Health and Healthcare During COVID-19, Lessons from India, Kenya, and the United States, Provision of Oral Health Services During the COVID-19 Pandemic. I would now request Dr. Murugi Nirangu, Director, Columbia Global Centers Nairobi, to please begin the session.
Good morning. I am Murugi Dirango, Director of Columbia Global Centers Nairobi, one of 9 centers across the globe established by Columbia University to create opportunities for shared learning and to deepen the nature of global dialogue. Today, in collaboration with Columbia Global Centers Mumbai, the University of Nairobi, and Columbia University College of Dental Medicine, we are delighted to host a distinguished panel to discuss oral health and healthcare during COVID-19, lessons from India, Kenya, and the United States. This discussion will be the first of a 2-part series. Oral health services have been severely impacted by the COVID-19 pandemic, with the healthcare system struggling to cope with the increasing number of COVID-19 patients worldwide. There has been a collateral decline in the provision of elective and non-emergency oral and dental services. This has affected not only access to and utilization of clinical dental services, but also community-based preventive programming and the education of dentists and dentists in training. To lead us in this discussion, I would now like to introduce our moderator, Kavita Alwalia, Associate Professor and Program Director, Postdoctoral Program in Dental Public Health, Columbia University College of Dental Medicine, to introduce our speakers. Welcome, Kavita.
Thank you, Murugi, for those very kind words. And I just want to take a moment to thank both the Global Center in Mumbai and Nairobi for hosting this 2-part event. As Murugi has already mentioned, the pandemic has really placed a huge burden on dental services, clinical services, community-based services, and the education and training of dentists. Although the mouth is central to eating and nutrition, communication and socialization, health, wellness, and quality of life, the access to and utilization of dental services across the globe is not equitable. The pandemic has made this problem even more stark. Public and private systems of care have been asked to provide only emergency and urgent services, in part due to concerns associated with the aerosolization associated with dental care, and also in some cases because vital PPE was redirected to medicine. Dental community education has been lacking. For example, most public health entities have promoted mask wearing, hand washing, and surface sanitation, but there's been little guidance regarding how to prevent infection via toothbrushes and oral aids, although they are very close to the mouth, which we think is the primary mode of infection. And advice on how to keep the mouth healthy during this time when dental services are severely curtailed has not been forthcoming. This 2-part series is designed to provide dialogue and learning about how safety net providers are addressing clinical, didactic, and community challenges during the pandemic. Today, we will hear how Columbia University is ensuring the safety of patients, staff, and students as its dental school begins to reopen. We will also hear about a new teledentistry initiative that went live during the pandemic at Columbia University. And similarly, we will hear from the University of Nairobi regarding delivery of oral health services, and will learn of efforts around triage and linkage to care from India. I now invite Dr. Biana Roik, Senior Associate Dean of Clinical Affairs at the Columbia University College of Dental Medicine, to lead us through the college's plans as New York City emerges from the epicenter of the pandemic in the US and by some measures, the world. Dr. Roik.
Thank you so much for this introduction, Dr. Lalwalia. It's a pleasure to join you. It's morning here in New York, and so it's a lovely day, and I'm excited to be here as part of this Global Center webinar. I am Biana Roy, newly arrived Senior Associate Dean for Clinical Affairs at Columbia College of Dental Medicine. I arrived in New York City on March 19th of this year, just as the pandemic was at just about to hit the peak here in New York City. So it has been quite a journey for me to join a fantastic team and to begin problem solving with this team and with the world, how we're going to readjust, reimagine, and recenter ourselves around the delivery of dental services to patients. Some of the objectives that I would like to cover today is around phases of preparation for restart for Columbia University, some key facilities considerations that we had to make, and finally, just a few words about COVID-19 testing recommendations. A very important part of the journey has been to really connect with our workforce and really understand where people are in their experience of the pandemic and their lives. As you know, on March 9th, a lot of clinics closed operations, and so our staff were remote, and so we needed to make sure that we can connect with them. So we deployed a number of surveys to all of our workforce to try to understand their attitudes about the pandemic and their willingness to return into the workforce once the pandemic starts to subside. And so we used it as a guide as we were preparing for re-entry into clinics. Additional surveying that we did was around our facilities, a needs assessment of our facilities. Me coming on board as a new clinical dean, it poses a good opportunity to take a fresh look at everything, COVID-related or not COVID-related. And as part of that assessment, of course, we focused on survey of our facilities related to airflow. So what Columbia has been doing is, much like everybody else, focusing on provision of emergency services during the pandemic. And the rest of the care was shifted off to telehealth. And this has given us opportunity to really start gearing up for the next phase. As we were seeing emergency patients that had to be seen, we were learning and working together to understand how to use those experiences to drive future experiences at Columbia. So there's an infection prevention committee that has been meeting weekly and doing a lot of work in putting together guidelines, updating guidelines as the guidelines from CDC and local governing bodies were emerging. And so that was a big body of work that has been put into place to prepare for a safe return. And the second thing that we did was, doing a walkthrough of all of our faculty practices and our teaching clinics, and really organizing a restart into 3 phases: a decluttering phase, facilities updates and improvements that had to be made, and finally a development of what we call functional workflows with a focus on social distancing wherever possible, and really integration of new guidelines and protocols to make sure that we can keep our people and our patients safe. So in the decluttering phase, we had to make sure that anything that was in the operatory that could not be thrown away or sterilized using regular EH&S protocols or decontaminated had to be not in the operatory. It couldn't be in the operatory. So at the end of the visit, if we couldn't do one of these three things, sanitize, throw away, or sterilize, it could not be exposed in the operatory to open air. And that was part of that reorganization of where the sundries would be, how they would be stored. We have large clinical spaces and entropy happens. So we had to make sure that we put in a lot of energy to put things back into good order. And what we did was a development of the idea of the model operatory. You can see some pictures here, best practices around covering large surface areas, even on the delivery arm, covering the entire delivery arm with barriers, because there's a lot of little knobs and little things that as we go through the operatory, we could decontaminate between patients. We do a very good job, but this is just an additional measure that we took to make sure that we're getting all the particles and anything that could be aerosolized. The second phase was focused on facilities updates. So I'll just touch on a few things. One thing that Columbia did was procure the intraoral high volume isolation device. We are outfitting all 200 of our dental chairs in the teaching college and 50 chairs in faculty practices to make sure that we have this proper isolation. We purchased also some additional external suction units from Vanguard in areas that could be such as orthodontics, where we could use some additional suction and evacuation during high aerosolized procedures. We walked around our clinics and determined where we might need to put up some additional plexiglass partitions. Even though all of our areas do have at least 6 feet of clearance between operatories, we felt that there are some higher risk areas where we'd want to be able to put some additional protection and privacy for patients. It's a big challenge for a lot of teaching institutions because teaching institutions often have a very open bay concept. And so in this environment, anything that we can do to personalize the space, we took those measures. PPE and the focus on procurement of PPE has been, a major source of work for us. As you know, the supply chain has been very much unstable for all of medicine, but also particularly for dentistry, as we were often considered as elective care and not necessarily front lines. And so, advocacy around PPE has been a really strong component of the last 3 months, trying to procure it for our staff and providers. And then we've completed airflow assessments to determine what additional measures we might have to take in our facilities, and I'll touch on that in a little bit. We have some rooms that are negative air pressure rooms, and we've confirmed that all have been tested and retested to ensure 100% compliance of those areas. And of course, we worked with the hospital facility staff to make sure that should we have a COVID positive suspected or confirmed case where we have to aerosolize to take care of the patient, that the facility staff would be well prepared to do an end-terminal event-based cleaning, specifically in the dental space. We are in a hospital, and a lot of times facilities know how to take care of an operating room, but don't have that same knowledge around specifically dental areas. So this is just an example. IsoDry is one vendor that we ended up procuring for the intraoral suction isolation. Having done research around this area, with this device is comparable to the use of rubber dam. As you know, rubber dam is not always possible to utilize with every dental procedure. So we felt that having the versatility of the intraoral high evacuation suction and the rubber dam, when appropriate, would really significantly reduce the aerosolized air. Additional measures that we are taking into consideration to reduce aerosolization is, we do have air-driven handpieces, and so we're able to reduce the torque and reduce the water supply to them to minimize the spray that's developed. We encourage hand irrigation wherever possible. We are encouraging reduction of ultrasonics use during the pandemic. Four-handed dentistry, so reorganizing our curriculum to make sure that student providers can help each other out during procedures, and extra oral suction in some areas. Another part of the phase 2 was the airflow assessment. And so the calculation of the exchange of air rate is usually measured by area volume added or removed from a particular space divided by the volume of space, and that's commonly known as air exchanges per hour. And airflow is generally measured in cubic feet per minute. So there's a bit of conversion that needs to happen to understand how heat, ventilation, air and cooling systems remove air and aerosolize viruses and bacteria from the environment. The Centers for Disease Control recommend that based on these air exchanges per hour, certain resting periods should occur between patients. There was initially a blanket statement of 15 minutes, but later on it was removed by the CDC because it does require quite a bit of science. 15 minutes may be too much or it may not be enough, depending on the facility in which you're practicing. So here's an example of air exchange per hour and the time required for decontamination of airborne particulates. So to achieve 99% efficiency for removal of airborne particulates. If your space has about 10 exchanges per hour, a resting period of about 30 minutes, 28 to 30 minutes would be needed. And so this is the information that we used as we did an assessment of our spaces. We understood what each space's ACH contains and provided recommendations based on that for how much resting time our spaces will need. Most of our clinics fell into approximately 15 minutes of resting time. Some fell into as much as 40 minutes of resting time. As we are revamping our operations and thinking back about how we're going to make sure that we are available and accessible and that we are practicing at a reasonable speed, but also keeping everybody safe, we're also looking at HEPA filtration options that could help us to clean the air a little bit more efficiently and potentially contribute to faster turnaround between patients by utilizing this technology. So we have a fantastic team that looked at pros and cons of various technology that's out on the market, looking at product specifications around CFM and the overall goal for reducing the downtime between patients. And we looked at product maintenance, how easy it is to use, and what replacement parts may be needed, how available the product is on the market. As you know, supply chain has been very variable. The health and safety ratings, the price point, the marketing, and how stable the company is and how likely we think it is to be on the market. EnviroCleanse is just one product that Columbia decided to procure, and we are in the process of installing these units in some of our areas where we feel it would really improve the turnover rate. And the final phase of preparations was around functional workflows. So we made sure that we have good processes in place. After we did our surveys for our faculty and staff and students, we learned that about 25% of our workforce feels some sort of reservations about coming back to work. And so it was very important for us to make sure that we can understand those barriers and meet the challenges so that everybody can feel safe coming back to Columbia. So we have screening measures in place, screeners at the elevator who take people's temperature as they walk in, as well as the COVID questions. If somebody is, looking like they're suspected of COVID symptoms, they are roomed immediately by passing all of the areas. We also have in our hospital workforce screening app for daily symptom checking for all staff and residents. This is another measure that the hospital took centrally to make sure that people are reminded to stay at home if they're not feeling well. Columbia was at the forefront of technology, developing a screening algorithm that updates the necessary information that was coming out of CDC, ADA, all of the regulatory agencies. And the algorithm helped us to make sure that we were sending to telehealth as many patients as we safely could, and only limiting in-person visits during the pandemic to those who absolutely had to be seen. Dr. Sharon Perlman, who's my colleague, she will speak in more details to you about the screening algorithm, which has been just an incredible work coming out of that area. Social distancing around reception areas, good signage, good huddles with the staff to make sure that everybody understands what protocols and what recommendations we are putting into place. Partitions were installed where appropriate. We reconfigured reception areas to allow for social distancing. This came together with workflow changes around how patients come into our practices, how quickly they're seated. A lot of the traditional check-in processes, collection of payment, things like that had to be reworked and either taken prior to the visit by phone or as much as possible chairside. Everything's brought chairside to the patient so that we can minimize the traffic that's in the reception areas at any given time. We are working on active enrollment of patients into the website portal to help with this touchless check-in. And really, preparing spaces for students as we're getting ready for their arrival back in our clinics to make sure that they have spaces to relax, and focusing on the development of staggered shifts so that patients, staff, faculty, and students are able to come into work and leave work at different times, have appointments at different times, and have their lunch hour and relaxation time at different times. And so some examples of how we approach staggered shifts is, social distancing really means reduced capacity, but it doesn't mean reduced capacity everywhere all the times to 50%. It just means reduced capacity of when people travel about our spaces. We need to be really clear about where people spend their time so that we're not overloading any one space. So Columbia focused on 60% scheduled capacity for August and about 75% for September, with plans to increase that to about 85% by the end of the year. We developed staggered appointments and times when people come and go to be able to achieve this goal. We're still working through vertical transportation on the elevators to make sure that we can safely bring people in. So as we are launching, we will be going back and forth to make sure that our plans to ramp up are appropriate. I touched a little bit on the workstation on wheels, which is a huge part of the functional workflow revamp. Whereas before, patients used to go to the treatment coordinator to review finances and treatment planning, whereas before, patients used to go to the front desk to schedule their appointments before they leave their visit. Now everything is on mobile stations. Staff are retrained with new processes to be able to bring these activities chairside to the patients. And finally, I would like to touch on testing, COVID testing. We are of course, following all the recommendations for healthcare providers around travel restrictions and those who are traveling having to come back and make sure that they're COVID tested before resuming their activities at work. But additionally, we focused on the strategies for testing of our patients. Columbia University sees about 600 patient visits pre-COVID a day. And so that's a big volume of people that we need to be able to accommodate somehow. And so to be able to do that, we really had to approach testing with a different lens and really categorize the invasiveness of the procedures as low, moderate, and high. So an example of a low invasive procedure would be an examination or a simple restoration. A moderately invasive procedure would be single tooth extraction and maybe some minor periodontal therapy. And highly invasive procedure would be something that would potentially require sedation, going to the operating room, or a more invasive type procedure that would have bearing on the patient's outcome if we didn't know for certain their COVID status. And so based on that, Columbia came up with some recommendations that patients coming in with either well-controlled systemic conditions or rather healthy are just simply screened. They're screened 48 hours before, they're screened with temperature and questions at check-in, and if screening normal, we proceed with the procedure. Moderately invasive procedures, it really is up to clinician judgment based on the patient's comorbidities, and we can have some decisions between screening and using clinician judgment whether or not we need to COVID test the patient. And for all of our high invasive procedures, we are recommending COVID testing for our patients. So I will pause here and thank you for your time. And hopefully I've been able to paint just a quick snapshot of what our teams have been doing in order to bring back everybody safely back into clinics. Thank you.
Thank you so much, Bianca. That was a very quick update of what I know has been a very deep dive into what's happening on the ground. And so I thank you very much. I know that it's been a lot of work that's gone into this, and yes, thank you for your leadership.
Thank you so much, Kavita.
Now I'd like to invite Dr. Sharon Perelman, who is the Chief Medical Informatics Officer at Columbia University College of Dental Medicine. She's also an assistant professor. The telehealth algorithm that Bianca mentioned was developed by Dr. and her team, and I'm inviting her to talk about that algorithm, how it worked during the height of the pandemic, and what plans are for using it as we keep going, trying to provide services during this unusual time. Dr. Perelman.
Good morning, everybody. Thank you for the introduction, Kavita. I'm delighted to be here today to share with you what we've done at Columbia to help us during this pandemic to be able to safely treat patients that are in dire need of emergency care and protect our staff and our faculty from potential exposure to COVID. So I want to start out by saying before the WHO even listed COVID as a pandemic on March 11th, the dean, Dr. Stoller at Columbia, decided to put together a task force of faculty and staff to monitor what was happening at COVID in New York City. News was coming out daily, recommendations were coming out daily, so we thought it was best to put together a task force, which we did. And within 2 or 3 days of putting that task force together, the dean decided that it would be best for us to postpone elective care for patients and focus on the emergency care of patients within the clinic. So for the first few days, once we did this, the residents in the hospital and the postgraduate residents were taking care of our patients in our emergency clinic. We had multiple walk-in patients. We had patients calling on the phone. They were finding out their dental practices were closed. And we anticipated an increased volume of patients coming into the clinic. I went down and talked to the faculty and the students in the emergency clinic, and they said, you know, we have all these patients coming in and we're having to defer them because they're really not emergency patients based on the guidelines we're seeing from the CDC and the ADA. So how do we prevent these people from, you know, coming in but still take care of the patients that need to be seen on an emergency basis? So that's how this whole algorithm came about. So we needed to figure out a way to combine all of the recommendations that were rapidly changing almost on a daily basis from the CDC, from the American Dental Association. As Dr. Biana said, our infection control committee was meeting on a regular basis to determine how safely to take care of patients. And the information was overwhelming. The faculty could not keep up with the recommendations. They were changing so quickly. So what we thought is that we need to develop a tool to help our faculty take care of these patients safely, and that's what we did. We had been on our newly integrated medical and dental electronic health record called EPIC for about 5 weeks before we had to shut down for COVID. So what we did is we looked at the tools that were available in EPIC and came up with a solution that we were going to develop an algorithm that would be a very easy interface for our faculty to use to determine what was the recommended course of treatment for a patient based on all these different guidelines. So talking to the faculty about the patients that were coming in, what they pointed out to us was that most of the patients that called on the phone said they were in severe pain, just about every patient. And those patients would come into the clinic and maybe they weren't eligible for care because of the nature of their emergency. So we really needed to determine, you know, what criteria should we use to determine whether a patient should be seen in the clinic or could they perhaps be managed medically via telehealth. We had a high variability of the recommendations that were coming from the faculty, since there were so many different faculty taking telephone calls from patients and screening them. So we decided to look at what are the most important factors to analyze to determine the treatment pathway for these patients. The algorithm that we developed begins with a screening of the patient's pain level. That was the most common reason that a patient would call. So we would do a pre-screening with a patient by a faculty member to determine what their pain status was like. Based on that, we decided to develop acuity levels, how we could rate these patients to determine what was the intervention required at the time, based initially on the pain screening and then following that, the screening based on dental conditions. And here's just a little flow chart of how we began to develop the algorithm. So what we did is in the EPIC electronic health record, we use some features within what's called a flow sheet to translate our flow chart into something that was user-friendly and had calculations done in the background to guide the faculty provider to a level of acuity, which would then drive what type of intervention we had for that patient recommended. So you'll see here, we have a pain screening questionnaire that the faculty would review with the patient. These are cascading questions based on the answer for that patient provides. So are you having pain? If you are having pain, then this additional cascade of questions opens up. Are you taking medications? Do you have pain relief with medications? Are you not taking medications? If you are taking medications, what are those medications? And then some quality of life issues to add to that. What we learned from the faculty, if you ask a patient, rate your pain, the typical 1 to 10, they told us that every patient would rate their pain level between 6 to 10. And according to the ADA guidelines at this point, that would require an in-person visit for every patient, which was just not tenable at this time. So we did some investigation and some calculations, really looking at more objective questions regarding the patient's pain rather than just scoring it. So after a patient has the pain screening, the faculty is going to go over some additional questions. They're going to ask questions about bleeding, about trauma, about swelling, whether the patient has been taking an antibiotic. Often patients were seen by or had a prescription from their primary dentist, but they were not open to see patients. So they started a prescription, sent them off to us. Are patients calling for dental clearance for a medical procedure? We still have patients that are undergoing chemotherapy and radiation and needed to have a consultation. There were patients who were seen and still had sutures in place before the COVID caused the clinics to reduce their care. Comorbidities, what comorbidities would influence the outcome of a patient's care based on including those with the screening algorithm that we developed. So if it was made a determination by these acuity levels that a patient was to come to the clinic for an in-person visit, then we went to a COVID screening to determine the likelihood that the patient has been exposed to COVID or what those COVID symptoms are. So let me just review the algorithm again here. Our levels of acuity ranged from no intervention whatsoever. A patient called, I just want to get my teeth clean. We would put them in a queue to follow up afterwards. They have some needs, but not emergency at this point. And we want to refer them to comprehensive care once we're back in session. Level 3 was a palliative care. Can we treat this patient by telehealth? Can we provide them a prescription and follow up with them until we are able to see those patients in the clinic? Again, if those patients are to be in the clinic, which was our level 4, we go through our COVID screening. Have they had a fever, shortness of breath, cough in the last 2 weeks, flu-like symptoms, loss of taste or smell, recent exposure to COVID? Have they been COVID testing, and what were those results? Based on all of those factors, we would make a recommendation for that patient. So the output of our algorithm was really to determine a pain level of a none, moderate, or severe, then an acuity level as the interventions that I just mentioned, no intervention, urgent, non-urgent, recommend comprehensive care, or palliative, come into the clinic and we will screen you in the clinic for your dental emergency, or in some cases refer the patients directly to the emergency room. The beauty of this algorithm that we developed was that we used the tools within the EPIC electronic health record to translate those questions that the faculty would review with the patient to our progress note. So the faculty would ask the patient the questions, they would click on the buttons, and as you'll see here, all that information with the click of a button is brought immediately into the progress note for that provider to make the documentation. If they were to order a prescription for that patient, that would automatically be in the note. The faculty didn't have to, write all that information again. It just came right into this structured note. About the structured note, everything in this note is a structured data with what we call a smart data element in the background. So we are able to query our database for any of these questions or answers to follow up for potential research for these patients. So this is what our algorithm looks like with the inclusion of both of our COVID screenings and our telehealth screenings, kind of putting those together. Our patients are not only screened by telehealth, they actually come into the clinic. And when they come into the clinic, we go through their COVID screening first. And depending upon the output of that COVID screening, if we think there's a potential that patient was exposed to COVID, then we would room them immediately to take them out of the general clinic population. And here they are going in through that screening. And again, these were our recommendations with no COVID or with COVID. And that is it.
Thank you, Dr.
Thank
Perlman. That during the Q&A, we'll have an opportunity to talk about what plans the school has for this system, once things go back to pre-pandemic times. I'd like to now invite Dr. Regina Mutavi, my dear friend, who is the Dean of the School of Dental Sciences at the University of Nairobi, to talk to us about how dental services are being provided during the pandemic in Kenya and the challenges that the profession is facing.
Thank you very much, Dr. Kavita. And thank you for this very important session where basically we're likely to be learning due to our stage in COVID-19. But yes, I would like to share a few points about what is happening in the country. As you've said, yes, I'm the Dean of the School of Dental Sciences, University of Nairobi, and we are going to share our experiences with the COVID-19 pandemic. COVID-19 landed in many other parts of the world before we were able to have our first case. And on the announcement of the first positive case on March 13th, the president issued a directive that all learning institutions consider closing operations by March 22nd. I must say the University of Nairobi Senate meeting at the building that is right there, main campus, met on the following Monday, which was March 16th, and all teaching activities, including the clinical teaching services, were closed effective that March 16th. And therein, we just began the journey of COVID-19 in Kenya. And the situation as at 10th of July, as you can see there, we're still on the rise of cases. We cannot really be able to say how soon we'll be seeing the decline. So what I'm sharing will most likely be from that background that yes, in Kenya, the cases are still on the rise. I know by yesterday, there were 10,000 cases and 197 deaths, but the numbers are just increasing by and large. And so what did we do with our training of dental students? Before COVID, of course, you can see our usual dental training facilities, semi-partitioned rooms, a little bit of crowded. And this model has been thoroughly challenged by COVID-19, and the whole of dentistry and dental practice has been. Immediately after the announcement of the first COVID case, we experienced a very interesting, and it wasn't unique to us, we experienced a very severe shortage of personal protective equipment. And we were left with no option but to close all our clinical services and only have very, very basic emergency services that we tried a lot to manage by phone and very minimal coming on site. The basic, of course, infection control could not hold anymore. So we have done a technical retreat and we are still reassessing the situation. We set up an infection, a COVID response committee at the school, which has covered quite some grounds, including the training of staff that I'll share. And so again, even our inpatient and operations were halted. And consequently, faculty were instructed to go through some training on online teaching. What the university did was to mount all the remaining lectures online. And this has been going on since March, actually. Some of our students had 14 weeks before taking examinations. And the online lectures have been going on successfully. And we're at a stage where we are now having the discussion on how do we bring back our students to the clinical area to be able to cover the remaining clinical practice before they can be able to be allowed to sit examinations. Our chances of graduating the class of dentistry 2020 still hangs in the balance, and we are hoping that soon we might find a way forward. But talking about just dentistry and COVID and generally the situation in Kenya, I found this on the social media, and I just thought I needed to share this just to demonstrate where we are at in dealing with our reactions to COVID-19. That, of course, the reason why the university closed immediately and not even allowed a week for training of staff before they could close was the fear that the amount of fear that accompanied the first COVID-19 case confirmation in Kenya was immense. Of course, we've made some progress, and we've gone reasonably well into the learning zone, where we are able to try to do our best under the circumstances. And I can tell you we are now oscillating between the learning zone and the growth zone, where we can bring about a bit of creativity in trying to handle COVID. But we still have a lot of people who are still in the learning zone. So that can explain why we probably haven't yet emerged to find a very firm solution. But we've been guided through the processes. Obviously, after WHO issued the directives on what to do with the dentistry and to only attend to emergency situations, the Ministry of Health also issued guidelines in April. And I think and I hear others also struggled with really separating what is a true emergency according to the professional definition and what patients term as emergency situations for them. That is still a very interesting point of a discussion, that some patients will still say they're in intense pain, and definitely that means then they should be allowed to come on campus. And it was not just the Ministry of Health, but also the Kenya Dental Association did exactly the same, reiterating the same. And at this point, we started to see some guidance on the required personal protective equipment if the staff and patients were to be protected. as is listed there by the Kenya Dental Association. They have a list of what should constitute some personal protective equipment. Normally, this led to some discussion, and the country has a large group of private practitioners, and so there was also a bit of push because total closure of dental clinics was generating lots of cases that required to be attended to. And the ministry guidelines were clear that you could only send those ones to the health facilities within hospitals. And the dental school has one such facility that was open for emergencies, and we received patients from private practitioners. But the conversation led to a revision of guidelines by the Ministry of Health, and therefore from around May 2020, there has been a little bit of improvement in the facilities that have prepared themselves and opened for emergencies other than the dental school. The national conversation continues on this aspect. How safely can we be able to provide services that consider the safety of the patient and the safety of the dental personnel, and the management of the waste that comes out of these procedures. And of course, as a dental school, I can report that the personal protective equipment presents a very, very serious challenge. First, because of the availability. Over time now, the personal protective equipment have actually become readily available. Sometimes quality may not be assured, but yes, we can find a few of these. And the biggest question we have is basically how to be able to make sure that our own, who a lot of times, because we are a government institution, have been paying highly subsidized fees. So the question is, are our services going to be affordable for the majority of the patients? Are we going to be denying a certain group of patients dental care? And can we be able to sustain dental practice in the way the COVID has actually pushed us? So this is one of the operating facilities that we use, and you can see we now have to invest in measures to clean up the air and reduce the aerosolized procedure, contamination of rooms. And like Dr. Spencer Johnson would say, the quicker we let go of our old ways, the sooner we can be able to enjoy new cheese. I think what we are dealing with right now, even as we have our committees working to finalize on what we require to reopen, is basically knowing that, you know, every day we try to understand COVID better. And although we have retrained all our staff and students and introduced a telephone triage, and we are trying to operate only on bookings only, in the long term, it does look like we have to shift our gear from the current treatment, therapeutic oriented dental practice, and really see if we can offer some prevention and promotive services, and reduce the numbers of patients that are coming with dental issues. Of course, that is why I still have a lot of unanswered questions. Yes, there was the debate with the WHO about whether, you know, aerosols are responsible for the larger transmission. Can we confirm that the viral particles there are actually viable and can cause transmission? And we hope this can become clearer with time. We still have debate about air cleaning protocols, what is effective and what is not, the rational use of personal protective equipment, how much is really adequate per procedure, and I know our teams are working on this. Of course, our biggest issue in our part of the world is the cost of dental treatment. Who will bear the cost of PPEs, and how will that affect the entire cost? And we already have a large segment of our population that is not covered by dental services. They have limited access. How will that be? How will they be catered for? So we are watching this development very keenly, and we are trying to develop, answers to most of this. But for now, I think I just needed to share my thoughts with you. Thank you very much.
So, Dr. Mutavi, thank you very much. You've brought up some very interesting questions about equity. I know that we had been struggling with equity before the pandemic, but now this has brought it into focus a lot more. And some of our participants have some questions around equity, which we'll discuss just as soon as Dr. Rajesh Rao from Manipal College of Dental Sciences, where he is the head of the Public Health Dentistry Department, will tell us what is going on in India around oral health services. Dr. Rajesh.
Yes, good morning one and all. I'll be sharing my experience about the Indian response to COVID-19. I'm Dr. G. Rajesh, like Dr. Kavita has just introduced. We'll be dealing with the discussion along these contents. We'll start off with the current scenario. Right now, we are looking at close to 9 lakh cases, that is around 900,000 cases confirmed in India as of today morning. And these are the number of active cases and number of recovered cases. We are glad to see that the number of recovered cases are quite high compared to the number of active cases. And this is how the COVID map of India looks. Okay, so it's pretty much all over the place. As far as the regulatory agencies are concerned, of course, the biggest regulatory agency will be the Government of India, followed by the apex body for dental education in India, that is Dental Council of India. And then there will be certain regulations which are unique to specific universities and then institutions. Okay, so as an institution, we are operating at 2 different campuses. So we have our own set of rules, and probably the departments have their own set of rules as far as postings are concerned of different faculty members. And we have many different national specialty organizations which have provided their inputs about different aspects about dental treatment and management during COVID times. This had to be routed through the apex body, that is Dental Council of India, and then top to bottom approach probably was followed. Now from henceforth, whenever I mention we, this is the we that I'm talking about. Mainly we are looking at the administrative heads like deans, associate deans, and my team members. We are also looking at patient care committee of the institution and infection control committee of the institution. So as a team, we have tried our bit. The first thing is triaging and screening. Now we had to look at initial criteria for triaging and screening and subsequent treatment of dental patients. So of course, this is the guiding document for us. The dental institutions are divided into different zones, or the patients visiting the dental institutions are also categorized based on their address as red zones, orange zones, or green zones. If a patient is from containment zone, it is very obvious that no treatment is to be provided for that particular patient. And of course, red zones, we are only looking at emergency dental treatments. Orange zones and green zones, we are looking at emergency and urgent treatment procedures only. Now we'll come to the descriptions of each of these treatments. All routine treatments have to be deferred. Okay, this is one standing guideline that we are following. And oral cancer screening, wherever it is happening as a part of screening programs, have to be deferred. As far as the location of the patient is concerned, this is the state government's orders that we get. This is, of course, is online. The order specifically tells about the building where the patient is located, then the area within the city or the village that the patient is located, and of course the city that the patient is located. The building's location, it gives very specific boundaries. North, it is bound by this, south, east, west. So it's a very specific document. So this is the criteria for different treatment procedures that are being followed. We'll have a look at what constitutes an emergency dental treatment. So you're looking at fast spreading infections like Ludwig's angina and uncontrolled bleeding of dental origin, severe pain which is not responding to routine measures, and trauma. So these are emergency situations which have to be treated, and these are urgent treatment procedures. So you're looking at pulpitis, abscess, and different things. You're also looking at those conditions which significantly affect mastication of patients. So this includes broken dentures, broken restorations, or even caries or periodontal disease. Whenever the patient says that he is unable to chew properly, so it constitutes urgent procedure. So these are the other urgent procedures that are listed. So this is the guiding principle for us from the past 4 to 5 months, I would say. And all treatment procedures should be undertaken first mainly through teleconsultation. The patient has to first call up the dental institution on provided phone numbers, and then there'll be a tele-triage, and then the patient has to come. Of course, consent has to be taken during COVID times. This is very important for medical legal issues and even for subsequent contact tracing and other aspects. And patient has to visit a dental institution only with prefixed appointments. Okay, so these are, of course, the ideal requisites. Many times we see that the ideal conditions are not followed by patients. Okay, and this is the circular from the university. This is the percentage of faculty members that are posted in the dental institution. Initially, when COVID broke out, we are only looking at emergency staff, which was handled by Department of Oral Medicine, Oral and Maxillofacial Surgery. So they were handling the emergency department. Later, as things eased out, we moved from 30% staff to 50% staff to 100% staff. We were working 100% staff over the past 1 month or so. Now suddenly there's a spike in the number of cases. We are probably receding back. Okay, so now we are looking at 50% staff who are working on alternate days, and we had to prepare standard operating procedures. So this was the first task that we had to do. So this is the patient flow. This is a sample SOP that I've put for you on the slide. When the patient comes, we have multiple locations. For one location, there are multiple entrances for the patients to enter. So it becomes very tricky in terms of infection control. So we had to block a few of the entrances and have a detailed workflow SOP. And then there was an SOP for triage. Patient treatment, of course, was straightforward. Of course, we also realized we need to have SOPs for laboratory procedures. Once you take dental impressions and you send the material for laboratories, dental laboratories, so there should be appropriate infection control mechanisms which are COVID compliant. Okay, so that was one small change that we had to make. There was also an SOP for radiographs, and we had to design new signages and standees regarding COVID, and we have to redesign the IEC materials, that is information, education, and communication materials for the patients. And certain departments had to have partitions made, to clearly specify which are the donning areas and docking areas. And then rotation schedules had to be given to all the faculty members, non-teaching members who are there. That includes dental surgery assistants, housekeeping staff, and GD workers, and all of those rotation schedules had to be made. Okay, this is regarding the PPEs. Now, there should be a slight distinction between PPE and PPE kit. So this was a new learning experience for us as well. So you're looking at N95 masks and gloves and goggles and all the paraphernalia. They are PPE, they are the personal protective equipment. But this one, this picture at the extreme right is the complete PPE kit. Okay, so we keep telling that this is the astronaut kit, okay, wherein the doctor looks like an astronaut. So at different levels, different PPEs have to be employed. All of us need not wear the PPE kit. So that is one big take-home message for us. These are the issues that we faced during triaging and screening. First is patient address. None of the patient will come and tell that he is from containment zone or he's from red zone. So we had to have his photo identity numbers. We have Aadhaar card, one card that is specific for specific individuals in India. We have ration card and other cards are there for identification. We also use the informal methods. Suppose if a patient says he's from one particular area, we had our non-teaching faculty members or even faculty members from that particular area who would probably slightly inquire a little bit more to confirm if he is from that place exactly. And many patients were angry, and patients in a rush, they used to say that the HOD, you have taken appointment directly with the head of the department. So we had to communicate with them properly, and we had to follow the standard operating procedures. Now regarding PPE, doctors, dentists had to be told specifically about AGPs, that is aerosol generating procedures, only required the full PPE kit. And many instances you did not wear the full PPE kit. And non-teaching staff had to be oriented regarding PPE kits. And even patients, we saw that many patients were walking in without mouth mask. So we had to place a box of mouth mask on our OP table specifically for the patients. And coming to dental education and training, we have moved to online platforms. We have changed 3 platforms, and in each of these platforms, there will be one initial orientation followed by a meeting or a description on how to conduct classes, and then how to record lectures and how to give assignments. So for each of these platforms, you're looking at 3 platforms, around 4 to 5 meetings for each platform. You're looking at around 15 meetings that we've had over a period of 4 to 5 months just for provision of dental education to the students. As far as postgraduate training is concerned, we also conducted final university exams on online platform. And this is a circular from the Dental Council of India about how to conduct dental, the final university exams. So these are the issues with dental education. So we moved to the online platform, which is a steep learning curve. There were internet issues when we were teaching undergraduate students. And during university examinations, we had to explain a lot of things to the external examiners who had come. So this is about dental education. As far as outreach programs are concerned, we have adopted 5 centers. We visited the centers personally, and we discussed with the people who are in charge of those centers. And then we informed about the services that are available in the institution. And then we have mooted an application for developing a mobile application, an app, phone-based app, to contact people in these outreach centers. And these are the issues we've had at outreach programs. First is community presence, community involvement is a serious issue. And different SOPs are there in different sectors. The government sector follows a totally different SOP. So when there are different SOPs, we focus on similarities. Okay, and there is fear and apprehension among people, especially in outreach areas. We have to communicate. As far as research activities are concerned, patient contact research will require SOPs, okay? And IEC, that is Institutional Ethics Committee, has moved to the online platform totally. We are looking at doing library dissertations which does not require patient contact. We're looking at in vitro studies, online surveys, web-based interventions. These all do not require in-person contact. So these are the issues with research. We are looking at publications. So we are clearing the backlog that we have of our previous publications. So this is the summary of our response for COVID in India. And the road ahead, if you're looking at how things are going to shape up, as far as triaging is concerned, we're looking at more patients because there is a spike in the number of patients. There'll be more norms, more infection control, and people are aware about PPE nowadays. As far as dental education is concerned, online platforms are here to stay. This is the new normal. And assessments is a challenge. Clinical training is a challenge in online platforms. And definitely there's going to be curriculum changes. As far as outreach programs are concerned, teledentistry is one thing that we are seriously looking at. Oral health education, all preventive procedures which do not require aerosol kind of a treatment. And social media is going to be all the more critical for patient engagement and community engagement. Regarding research, there is need for evidence for everything, which PPE is effective, which how do we deal with aerosolization? How do we inform the patients? So there will be a question about what works best in certain circumstances. And online tools are here to stay as far as research is concerned. I would like to end this presentation with what Winston Churchill told his parliament. This was his first speech after taking over as the Prime Minister of UK. So he told, I only have blood, toil, tears, and sweat to offer. So it's going to be an uphill task for us. But on a positive note, this is the famous saying from the Bible, this too shall pass. So we just have to be that patient till we get there. Yes, thank you.
So thank you to all our presenters today. There is one question for Dr. Rajesh. And Ashwini is asking whether you are providing care for patients from containment zones, even when they have an emergency. So in other words, when a patient is from a containment zone and they have an emergency, are you providing care?
I would like to thank Dr. Ashwini for the question. Such patients will be treated at the medical college OPD by the oral and maxillofacial surgeons. So they are the first point of contact. And once the patient is stabilized, all the vitals are stabilized, then based on the nature of the injury, if it is injury, it is oral and maxillofacial surgery department. Surgeons will be handling the case. If it is an endodontic treatment or conservative dentistry, once the patient is stabilized, and once the patient pain and all the other symptoms come down, then the endodontist will give an appointment, and on based on prior appointment basis only those patients will be treated. But from the going by the question, in case of emergencies, it sounds more like a trauma kind of a case that Dr. Ashwini is referring to. Those patients will be taken care by the medical college OPD, where oral and maxillofacial surgery staff will be posted. So they'll be handling those emergencies.
Dr. Mutavi, I know that you responded to a question about whether there was a higher number of deaths in low-income and marginalized communities, and you said that those are not linked to COVID-19. However, I just wanted to open up the discussion to equity around oral health and oral health services, because I think this is something that we struggle with in most parts of the world, but especially in Kenya, given that there are such a small number of dentists for a fairly large population, just about 900 dentists in the country. As the pandemic rages and as you are unable to provide services like you normally would, how do you think the country is going to deal with a huge number of patients with a huge number of needs when you are actually ready to open up?
Well, thank you, Kavita. That is quite a tough question to answer, because I do not think we really have the answer at the moment. It is true that dental services have come to a halt. It is also true that majority of our patients tend to come to us when they have severe infection. And so we expect that we are going to have much more complications and patients requiring much invasive procedures because of the infections to be able to be stabilized. Whether we're going to be able to cope, I mean, that is a different dimension, because right now I tell you that all resources, and you mentioned that we are in a resource poor setting, so all government resources are actually completely directed to be able to manage patients with COVID-19 disease. So it's difficult to try and really have the rest of the services resume to a certain degree. And so I do expect that we're going to have to deal with more severe infections for dental patients as we go along. And I think the fact that patients cannot just access services is also going to have a lot of complications by itself as we emerge from the pandemic.
So I think some of perhaps what can be done is maybe more targeted community education, and I think perhaps some public-private collaboration around education of community, because a lot of the morbidity associated with oral disease can be mitigated by good home care. And I think promoting, you know, home care, teaching people how to keep their mouths healthy so that we can, you know, prevent some of this huge tsunami of disease coming towards us might be prudent, especially in resource poor areas. I wanted to let the participants know that there will be a similar webinar next Monday at the same time. But during that webinar, we plan to discuss more about how dentists are being trained, the issues and the challenges around remote training and learning. And we will also hear about an innovative community education program from a university in New Delhi, where they have been training teachers, since teachers are mostly interacting with children, and children live in families. So the hope is that the child will take back what they've learned from the teacher to their family. I want to thank all of our panelists today. As you can see, everyone had a lot to discuss, and I really wish we could have had a 3-hour webinar, which obviously is not an option. I hope that all of you will register for next week's webinar and look forward to more discussions. I am just very grateful that the Global Centers gave dentistry an opportunity to discuss the issues and to begin this dialogue. Good night in India, good evening in Nairobi, and good morning in New York.
Thank you, Kavita.
Thank you.
Thank you.